Phil, do you think that the patient positioning while doing an extra elevator APE affects the quality of the APE specimen?
Right, well, what we know for certain is that when we compared extra elevator done in the prone position and the supine position in this study with the European surgeons and Torbjörn, Bill and Brendan, was that the rate of perforation was much higher in the supine cases than in the prone position. So we have some direct evidence there that actually you reduce the perforation rate by getting the better visibility. I think the other problem we have with the supine operation in the lithotomy position is that different surgeons use different positions and different surgeons dissect in a different way. So Harm Rutten in Eindhoven now has a technique where he dissects from posterior, lateral, leaving the abdominoperineal specimen actually hanging from an anterior pedicle. And we've seen other surgeons like Strasbourg and Joel Leroy doing the operation in that position, but doing a different technique. So I think the big advantage of the way that Torbjörn's approached it is, of course, that we now have standardization of the operation. And once you standardize, you can improve it. But in the supine lithotomy position, and we know that that's the older method and it's not as effective generally in the hands of most surgeons, we don't have standardization. And so if we're going to move ahead with that side of it, we need to standardize the operation, do it one way, and then we can truly compare prone and supine effectively. But at the moment, the prone position has advantages that Torbjörn's been mentioning. That's not to say that the supine position couldn't necessarily achieve it, but is it as easy to achieve in the hands of all surgeons? And we have still got a lot of questions to answer as we move forward to dropping the local recurrence rates and improving the survivals.